Good afternoon and a warm welcome to the 12th Singapore AIDS Conference. My name is Chen, and on behalf of the organizing committee, I would like to thank all of you for being here today, virtually of course, to embrace this special occasion. The Singapore AIDS Conference is a biannual event, and it was first presented in 1998. This year's conference is co-organized by Action for AIDS, the Department of STI Control, the HIV Program of National Center for Infectious Diseases, and National University Hospital. We have put together an exciting lineup of speakers and panelists. So wherever you're joining us from, we hope that you will benefit from the program and take back some useful information and ideas. If you have questions along the way, just type them into the Q&A box. The Q&A box is located at the bottom of your screen. We will try to accommodate as many questions as possible. Please also know that by default, you have joined the conference in audio-only mode, which means your audio and mics are off. If you get disconnected, just click on the Zoom link again and we will let you in. Thank you for your cooperation. Without further ado, I am honored to invite Professor Roy Chan to welcome the first plenary speaker.
Welcome to the 12th Singapore AIDS Conference. 2020 has been a very different year than any of us could have ever imagined. We're in the midst of a once-in-a-century pandemic that has killed over 1 million people and sickened tens of millions of others across the globe. Our offices and workplaces were closed for months, and the economy is taking a massive hit. Businesses, organizations, and livelihoods are in jeopardy. Our futures have never been more uncertain. However, optimism is needed. We have all learned new ways of staying in touch and keeping our work progressing despite all the challenges thrown at us. We have adapted our programs to continue providing and improving clinical services, education, and prevention. COVID vaccines are coming, and the pandemic will eventually wane. It's against this backdrop that we are presenting the 12th Singapore AIDS Conference. Our theme, HIV and STI in the time of COVID-19, highlights the enormous impact that COVID has had on HIV and STIs, and how our plans to prevent and end HIV may have changed as a result. Sustaining the HIV response will be critical in a period when funding may be reduced as other priorities take hold. Not just COVID, but also AIDS fatigue and the advent of other global crises like climate change all make it harder for the HIV community to be clearly heard. We also chose to highlight the endemic interconnectedness of HIV and STI, the epidemiology and programs. Almost all HIV infections are sexually transmitted. STIs can increase transmission of HIV, and HIV can alter the clinical manifestations and management of STIs. Prevention programs for STIs will impact on HIV and vice versa. This point is clearly exemplified by the effect PrEP can have on the incidence of other STIs and the valuable opportunities for enhanced STI control that they provide. We are very grateful for our eminent plenary speakers for committing their time to share their expertise. Mr. Eamonn Murphy, Professors Seong, Andrew Gulick, and Sharon Lewin. Thank you also to the other speakers for their participation in the panel presentations and discussions that will follow each plenary session. Our sincerest appreciation goes out to the industry sponsors, Janssen, GSK, Gilead, MSD, and Roche. Your generous and reliable support over many years has enabled us to organize this AIDS conference. Last but not least, my fellow members of the organizing committee who have put together an excellent program. And also thank you, the audience, our virtual audience. We hope all of you will find the talks and discussions stimulating and informative. Without further ado, I'd like to go on to the first plenary session. We are very indeed pleased to have Mr. Eamonn Murphy, who's Regional Director of the UNAIDS for Asia Pacific, based in Bangkok. As Regional Director for Asia and the Pacific, Eamonn Murphy supports countries across the region in achieving the goals outlined in the 2016 UN Political Declaration on Ending AIDS. It leads and facilitates a joint UN response to support countries and their HIV programs, which includes strengthening the links between governments, civil society, the UN system, and development partners. He served as the UNAIDS country director in Myanmar, where he supported Myanmar's significant scale-up of services and helped to create an enabling environment and overcome legislative obstacles. Prior to that, he served in Vietnam as the UNAIDS country director, where he was honored with the Order of Friendship by the President in 2010. And before that, also the UNAIDS headquarters as Director of Governance, the UN system, and donor relations. Before joining the UN, Mr. Murphy was Director for Health Services with AusAid in the Foreign Ministry, as well as the Assistant Secretary for Communicable Diseases and Environmental Health, and Director of the National AIDS Program for the Commonwealth Health Department. I'd like to welcome Mr. Murphy to deliver the plenary lecture.
Thanks very much, Roy. Good afternoon, colleagues. It's a great honor to be here with you this afternoon to discuss these important issues that are affecting all of us across Asia and the Pacific and globally. In my remarks this afternoon, I'm going to shift slightly and look at the reality that COVID is with us for some time. The foreseeable future, vaccines are being discussed. The potential is there, but the rollout will take quite a long time. And for many of the populations that we work with and serve in the response to HIV and AIDS are going to be the most marginalized and low on the list of those who will access these vaccines when they become available. UNAIDS is part of the global movement to make vaccines free to all people everywhere. And this is a critical issue and a lesson we've learned from HIV. Because as we'll recall from the early days of HIV, it was the wealthy and those with access and advantage that could access treatments, and the cost was phenomenal for people in developing countries and populations. So it's how do we respond and deal with the reality? Now, I'm hoping this works. Sorry, Right, okay. So let me just start by a quick overview of where are we at and what's the impact of the of COVID in terms of the response. But firstly, this slide I'm presenting here, you can see to the right on the top of the slide, the countries in red. What we have in Asia and the Pacific, when we compare it to the rest of the world, I liken it in a lay person's terms to being a bit of a middle child in a family, and often the middle child feels overlooked. Asia Pacific, we're not doing as well in the response as East and Southern Africa is doing today, but we're not doing as badly as other parts of the world where in Latin America, the Middle East, East and Central Europe, Central Asia, we're seeing significant rises in new infections. In the period 2010-2019, we've seen a 12% decline. But we are not seeing a shift from that. The response has stagnated for a number of years. And what we are now seeing is a growth in certain countries in new wave epidemics. The Philippines, with the fastest growing epidemic in the world, with over 200% increase in the same time, is offsetting the decreases we're seeing in Singapore on the far left, and other countries. And when you think of China, India with large populations, these are significant numbers. But we are seeing, particularly among young, under the age of 25, in the Philippines, the new epidemic is under the age of 25. It's more than 85–90% of new infections are young, MSM and transgender. And Ambassador Birx, the global ambassador for the US government's PEPFAR program, she describes the Philippines as having two epidemics, the old historical one and this new epidemic. We are seeing in other countries next door to you in Malaysia, rising new infections again amongst the young MSM. And so there are a number of factors in this. Other countries, different issues, but we are seeing some countries where the epidemics are just not being responded to. The AIDS-related deaths in the lower half of the slide, there has been a 29% decrease. But in terms of AIDS mortality, we are not having the benefits of the health systems that we have. So there are serious issues in terms of quality and access, where mortality rates are lower in in South Africa than they are in most countries in Asia and the Pacific. So there are some serious issues that need to be re-energized. The epidemic, new data this year released, makes it even clearer what we're dealing with in Asia and the Pacific. 98% of new infections are among key populations and their partners. But their partners, the clients, the sex workers and partners of other key populations, only make up 21% of new infections. And we've got to keep that in mind, because often the programs and people talk as though we're talking in a general community type response, when we really, really need increased targeting of the responses. 44% of new infections among men who have sex with men. You look on the right-hand side of this, and when we talk about people in the 15 to 24 age group, and as I said, many countries are seeing rising new infections in this population, MSM account for 52% of new infections. So this is significant when we look at where do efforts need to be targeted. And we also need to look at how efforts need to be targeted. The programs that have been implemented for a long time may be not reaching or being nearly as effective as they were in the past. We are lagging behind, particularly in prevention. And I won't go through the specifics of this slide, but this just shows you a snapshot across the 4 key populations that are affected by HIV in this region. The fact that we have epidemics principally amongst key populations that do not enjoy the same civil liberties and rights and equality in society in most of the countries in our region causes major obstacles to effective programming. But critically, governments are not investing in prevention services. They are putting their slowly increasing contributions to treatment, and we can't treat our way out of this epidemic. So testing, STI control, PrEP advances, a whole range of new innovations need to be fast-tracked to make sure that we're actually going to catch up. But you can see here the range across the region in different countries. Treatment, we are still far from meeting our priority goals, the targets that the countries, the member states of the United Nations set for themselves. So all countries, including Singapore, signed up to it. Here you can see the countries that have achieved the 90% of people living with HIV who know their status, and then people living with HIV on treatment, and then those who have viral suppression. And it's significant in each of those, when they get unpacked, that we have a major gap between testing and transfer into services for treatment. And we're losing people at that point. There's a number of different reasons in different countries, but stigma and discrimination is still the most critical, both within the health system and in the general community. But so this following up with people who test positive to ensure and support them in treatment is a serious concern. We also still have a lot of people who are fed misinformation about the impact of treatment that deters them from taking treatment. But you can see Cambodia is the only country outside of developed economies like Australia and New Zealand that have achieved these. Viral suppression, now this is a challenging one because many people only get a viral load test once a year. So it's not really as effective as we'd like to see, and particularly if you're thinking of the concept of U equals U, which is scientifically proven. But you need to know your status and be able to monitor your own health and take control of it. On the right-hand side, which I won't go through, you can see the variation when we look at children, women, and men. Just as I start going to look at the impact of COVID, we need to keep in mind that the COVID pandemic is threatening the progress the world has made in health and development gains over the last 20 years. These are across the board, all areas. I've seen reports just this week on the setback of gender equality, taking us back more than 20 years in advancement in countries. The economic impacts are undermining, particularly the informal sector in many countries, where people have just lost jobs, are unable to find alternative employment, and development gains are being set back. This also includes the gains that we've made against HIV and other communicable diseases. COVID-19 seriously impacted the AIDS response. Even before COVID-19, though, many countries, including our own region, were not on track to meet the global targets for 2020. Now COVID-19 crisis risks blowing us way off course in particular countries. And we're going to see that again next year, because that's significant that this is not going away anytime soon. It's widening inequalities that already existed, but the gender inequality, racial inequalities, social and economic inequalities, we are becoming a more unequal world. This slide just shows some very quick examples. The top is the only one I'll focus on. In the light blue, treatment access in the first 6 months of 2019. Compare it to the red in the first 6 months of 2020, and you see a direct impact of the switch and the focus on COVID-19 responses, and particularly lockdowns that were initiated in many countries in the beginning, often more a law enforcement lockdown than a public health lockdown. So significant impact was seen. When we talk about HIV and COVID, the intersectionality, which is the list in between the two, these are the same issues we've been dealing with HIV for many years. People in certain settings like prisons, the biases, the laws, the policies, issues of access, be that income, employment, homelessness, segregation in society. These are the underlying inequalities that make you have worse outcomes when we deal with the issue of COVID-19, just like they do HIV. So again, the inequalities focus must be central to the response. A few examples from our region. Cambodia, we've done a lot of studies with countries, with community groups across the region to see what the impact is. Here, a country survey found that 37% could not access contraceptive services. 22% unable to obtain condoms because of lockdowns and new measures that were put in place. Respondents expressed the need for access for their medications for opportunistic infections. Diagnosis and treatment of STIs, particular rise in issues around psychosocial and mental health issues across the region in all countries that we're working with. And you can see here, a lack of information on how to access support and services for psychosocial or mental health. Pre-exposure prophylaxis, information and supplies were limited and disrupted. The big impact in terms of ARV disruptions was because of both the ingredients to go from China, particularly to India, the major market for production of generics, and then from India with interruptions of flights to countries, and then the distribution within countries. These have largely been sorted out, but in the beginning there were some significant issues of risk that had to be addressed. A few particular examples when we look at different populations. More than 80% of women living with HIV in our region, in partnership with the International Coalition of Women Living with HIV, we've done a study, and they reported lack of access to sexual reproductive health and rights, including contraception during the lockdowns. Significant increases in domestic violence, both for women living with HIV, people from key populations, particularly men who have sex with men, who are having to spend more time in localized environments where they're at risk of violence from their family or local community, because everyone's under increased stress when it comes to COVID. Young key populations are particularly an issue for them, where they are looking at mental health issues, psychosocial, access to testing, access to PrEP, which they were having. And when you consider this is where rising new infections are going, this is serious for us in terms of services and disruptions. Access to condoms, the basic commodities that we take for granted. So these are serious disruptions that are occurring. Of course, for LGBTI populations, the existing laws that criminalize sexual orientation, gender identity, and expression exacerbate the negative health outcomes. We've seen in some countries where LGBTI communities have been targeted and blamed for spread of COVID. We saw this directly in South Korea, where nightclub settings were seen as a source of infections, and the communities were blamed. We saw the same things, obviously, with the early days of HIV. So no difference in the fear causing stigma and then coming out as discrimination against populations. Transgender women have reported difficulties in many countries in accessing essential therapies. But COVID-19 is also a wake-up call. It's an opportunity to do things differently, do it better and do it together. In many respects, the defeat of AIDS as a public health threat depends on how the world responds to COVID-19. Community resilience and innovation shown the way, and I'll give some examples in a moment. In mitigating the impact of COVID-19 on HIV, and I'm also very proud over the last year how many members of the HIV movement have been mobilized to defend both our progress for HIV, but to stand up for people living with HIV and key populations, using the structures, mechanisms and networks of HIV response to help push back the coronavirus and improve the response to it. National AIDS program staff have been moved to COVID response. The significant health system strengthening work that had gone on is being redeployed. This, of course, has an impact on HIV in the first place, but it also has an opportunity to show how investments in programs like this have benefits to new and emerging infectious diseases. Whether advocating for multi-month dispensing of treatment, organising home deliveries of medicines, providing financial assistance, food and shelter to at-risk groups, HIV activists and affected communities have shown again they are the mainstay of their HIV response, and their expertise and skills have been used for COVID. So I won't go through all the specifics. There are different examples where there is a need for change, but one of the most critical is how do we reach people? And one of the lessons learned that we've known for some time, and COVID has made even more obvious, is we need to make greater use of the media, social media, the internet. Young people live in this space, and when they are becoming the larger part of new infections, at risk of new infections, we need to reach them, both with information and how then to connect them to services. We need to shift from the traditional outreach services and use social media, mobile phone, much more. The dating apps for heterosexual, MSM, gay, all the same. We have great challenges in the issue of party drugs or chemsex and access to services. This is the way to get around this, by using the space that the young people are communicating and engaging in. And it can be traditional like Twitter, it can be a whole range of different means that they're using in different places. So an analysis and understanding of different countries is critical to understanding how to use these. New trials of antiretroviral treatment, multi-month dispensing has been put in place. A few examples here from across our region. The Philippines, both telemedicine, PrEP delivery, the use of pharmacies for delivery of PrEP. PrEP obviously is an issue for Singapore to consider as a major tool in reducing infections. Adapting service delivery in Vietnam, again on PrEP. In Vietnam, they're also using the internet in very innovative ways to reach people who will never come forward to the traditional services. And the numbers of people who have not tested but are at risk are being identified at very high levels, and then accessing online services, sending out test kits and following up with counselling online, and then connecting them to services either for continued prevention or for treatment. Same, we're seeing community dispensing in a number of countries, India, Nepal, Thailand. We're also seeing key population-led services being utilised by governments to help multi-month dispensing both of ARVs but also of PrEP in a number of countries. Regional networks have stepped up and are providing information to their country networks and making sure as much information both on COVID and how to deal with HIV in the reality of COVID as part of our lives is shared, so that the information is clear and coherent across the board. In terms of way forward, in many countries, one of the most critical issues that's not being addressed is how do we integrate the HIV response? How do we mainstream aspects of it over and above just the simple treatment side of it? And one of the most critical issues for us, and obviously this is an issue for all countries, including Singapore, is what's in universal health coverage. And some are much more advanced in this. The Minister of Pakistan, Minister of Health, has recently announced that HIV prevention services, and they've named specific services, will be included in their universal health coverage essential services package, not just treatment. So countries like Pakistan can do it, many others can, and they're setting the way for that. Whilst their epidemic is in a crisis mode and new infections are rising significantly, and there's way too little treatment in that country. This is a significant structural change that will help.
Eamonn, you've got 2 minutes more.
That universal health coverage should be talking about systems for health. And that's where community groups, be that advocacy, be that service delivery, are essential. It's not just the health ministries, the health systems. We need multi-sectoral responses, just like we do for COVID. It's got to cover the full spectrum, not only treatment. Equity and development priorities and social inclusion have to be central. This is about the people. Eliminating stigma and discrimination, putting people at the center, and grounding our responses in human rights and gender responsive approaches are key to ending both the colliding pandemics of HIV and COVID. And this is where universal health coverage needs to be refocused. So it's not just about health financing, it's not just about a minimum package, but it is about the individual and not the diseases. This is a significant shift that we need to see across the region as universal health coverage is rolled out. It is both an opportunity and a risk for the response to HIV, regardless of COVID-19, but COVID-19 has amplified it. It's seen as a new health security issue. And so that's why it's critical for us to be working and supporting both COVID-19 as a way to remind countries that they need to invest in pandemics that are still ongoing, be that tuberculosis, be that malaria, be that HIV. And it's not over till everyone is able to access services, and it's over for all, and not just for part of the populations. I'm really looking forward to hearing the presentations in the rest of this afternoon's session and the panel. And I really appreciate the opportunity to be with you today, albeit in the virtual space. It means that we can be in many more meetings across the world. On Thursday, I was in Berlin in the morning and Japan in the afternoon, something we couldn't have done pre-COVID. So this is a new opportunity for us to be able to engage together and discuss issues of common concern to many countries across the globe. So Roy, thank you again to you and the committee for asking me to join. And I hope this has set a few ideas that we can tease out in discussion and through the other panel speakers. Over to you. Thank you.
Thank you very much, Eamonn. I think the remarks have been very thought-provoking, and in particular, the way we are going to administer our programs. We've heard all about telemedicine in the time of COVID, and going forward, and I really think that we need to be assertive and be inventive about how we're going to provide more prevention, particular PrEP, making use of the virtual space and not insisting that individuals see healthcare practitioners, and also to use other healthcare providers. There are several questions for you from the audience. Perhaps I can just pick one up because we don't have very much time. The question is from Jason Wong. Given the majority of new infections are occurring in key POPs and their partners, does UNAIDS have any power in redirecting more of the current funding towards programs that address these groups?
Thanks very much, and I see that's from Jason. Jason, that's the most challenging issue. When governments are directing services, we still see some governments where we know the epidemics are rising amongst young adult MSM, and they still spend far too much on general community education. This is the greatest challenge. What we now have is a new global strategy that will be released at the beginning of next year. And as part of that, we'll be redeveloping with the countries across the region an Asia-Pacific specific roadmap. And as part of that, ASEAN countries will be critical. That's where Singapore can help in pushing the message that this is exactly what needs to be done. And that's why the new data this year is showing it's 98% and making it clear you can't opt out and say it's a general community epidemic in any country in our region. We may have some rising new infections among young heterosexuals in certain countries, but it is not a generalized epidemic. But we do not have the power, because obviously it is each country's government that makes the determination on their funding. We're still far too reliant on international funding for prevention in these countries, and that is declining rapidly. So that's making the shift. Do we have to go and end up in the Philippines scenario before countries recognize this again? That's what we've got to avoid, and that's why a new roadmap, both for the Asia-Pacific region, but particularly for ASEAN member countries, is critical for us during next year.
Thank you very much, Eamonn. I think we have to move on to the first panel discussion. I'd like to invite the panelists into the webinar. And this discussion is specifically for the impact of COVID-19, what impact it's had on our HIV and STI programs in Singapore, and a really wonderful panel of presenters. I'll just go straight ahead to introduce the first, my colleague, Dr. Wong Seong, who's a consultant physician in the Department of Infectious Diseases, Hospital, as well as the NCID, the National Center for ID, where he is head of clinical HIV program and the deputy director of the National HIV program. His clinical and research interests are in HIV medicine and the social behavioral determinants of HIV and other STIs. He's also actively involved in medical training and is the program director for the National Healthcare Group's ID residency program. Chen Seong.
Thanks very much, Roy, for that introduction. And as Roy was saying, what I'll be talking about today is really about the impact of COVID-19 on clinical HIV care in Singapore, with a special focus, I think, on the program that I lead at the National Center for Infectious Diseases, which is the largest HIV program and the most established one in the country. If I could just get control of my slides. Just give me a second. Excellent. Okay, so I think as most of us, I'm just looking at the participants for today's conference. I think many of us are actually from Singapore and might be familiar with the early response or the nationwide response to COVID-19 in Singapore. There were health advisories that were issued in the country very, very early on in the pandemic. And this brought about a broad suite of what I term and what has been termed as whole country measures, of course involving public health, but also wide-ranging social and community level interventions meant at stemming the new infections of COVID-19. Guidelines on the management as well as screening of cases, both suspect as well as confirmed cases, were rapidly developed, disseminated nationwide, and progressive restrictions, like we said, were implemented even sometime before the World Health Organization declared COVID-19 a pandemic in early March. Now, all of these did have an effect, obviously, on clinical HIV care provision. Now, while there has not been much data that's been published about the epidemiology of COVID-19 people living with HIV, especially in Singapore, we do know that there has been some impact. Now, the basic some background into how HIV care is provided in Singapore. Most of us may be familiar, but it's still largely centered in restructured and specialist hospitals, in specialist clinical HIV programs. Patients come to clinic on a regular basis, and services are provided within these brick and mortar institutions. The basic principles, therefore, that arose during the COVID-19 pandemic was really centered around keeping patients safe and keeping staff safe as well. So reducing a need for patients to attend hospital visits and clinics wherever possible, ensuring, of course, that there was uninterrupted access to medications and uninterrupted access to other services as much as possible. Now, I want to just sort of take a step back and look at what the epidemiology of COVID-19 in people living with HIV has been globally and internationally. And I'm not going to go through all of these slides, but it just goes to show you that while a number of series and case reports have been published in the international literature, by and large, the numbers are not exceedingly high, which really sort of begs the question, and I think that's been better answered in other settings, about whether people living with HIV are at increased risk of COVID-19 or increased risk of severe COVID-19. And I think as far as the published data is concerned, the jury is still out. So even in very large centers, even in city centers which were disproportionately affected by COVID-19, especially slightly earlier on this year, we see that the number of people living with HIV who were diagnosed with COVID-19 was not high or higher than expected, especially given the postulations of people with HIV having compromised immune systems and therefore potentially being at increased risk of COVID-19. Now, there has been some, I think I've alluded to this already, there does need to be some caution applied when interpreting the evidence of COVID-19 in people living with HIV in these case series, because in most of these settings, there's either no universal HIV testing for people who present with COVID-19 or no universal COVID-19 testing for cohorts of patients who are under care for HIV. And so until we have appropriately powered and designed studies to draw some conclusions about this, we just have to sort of bear that in mind. There has been one published case in the literature of a Singaporean patient with HIV who was diagnosed with COVID-19, and this was a paper published by my colleague, Dr. Louisa Sun. The patient thankfully had a relatively mild and uneventful course of disease, but just to show that we have seen these situations and these patients. Now, this slide is sort of put here just to give you an idea of how, in fact, people have been affected and patient attendances have been affected. And you can see the line in red and the line on orange and the lines in gray sort of represent numbers in 2019 and 2020 respectively in terms of the monthly attendances for HIV care at our HIV specialist outpatient clinic at NCID. And while it has been generally much lower than before, it kind of parallels the period of time when we were on what we call, during circuit breaker, when we really wanted to reduce the number of attendances to clinic. But if you take a look at where November and October is, the numbers are so fast approaching coming back to normal. But what I want to talk about is this time frame in between February to July, when we really were trying to reduce the number of visits that our patients had. So how was the clinical care impacted? Obviously, we wanted to make sure patients didn't have to come back to hospitals where they might be at increased risk of maybe getting infected or getting in contact with a COVID-19 infected individual. We also have to realize, as Eamonn sort of alluded to, many HIV physicians are actually, we are infectious diseases physicians and we're actively involved in the COVID-19 response, both clinical as well as public health. So there were manpower issues on the ground as well. However, the primary concern that we have and the primary goal of providing HIV care is to ensure that our patients remain safe and receive the care they need. So there were put in place a number of algorithms and interventions. First of all, deferring appointments wherever possible through a process of careful patient selection. No deferrals and no delays in terms of seeing people with newly diagnosed HIV during this time. So all newly diagnosed patients were still seen within a week, which was something that we have been doing during peacetime as well as during COVID response. And we also ensured that we did not interrupt rapid or same-day initiation of ART where it was indicated. However, what we did do is for patients who were stable on care, seeing whether we could see them in 9 months rather than 6 months, assuming that they were well, and keeping in contact with them via telephone call or video consult, something I'll talk about on my next slide. Now, we also took care to ensure that there was no interruptions in medication, and this is something as well that Eamonn and Roy both alluded to. We ensured that keeping track of the international supply chain of medications, dispensing medications in shorter or smaller amounts to ensure that there was we didn't run out of medications should the supply chain be interrupted, by ensuring that patients still received the full amount of medication that they needed, just in sort of smaller installments. We implemented and encouraged the uptake of free home delivery of medications, once again to reduce the need for patients to attend clinics. Now, one thing that we also pivoted to, not just in our center, but from my communications with the other hospitals as well, is really pivoting towards teleconsultation. Now, we started this even prior to COVID-19 in recognition of the fact that attending a brick and mortar clinic and a face-to-face, a physical visit may sometimes present patients with some challenges, right? They needing to take time off work, coming down to clinic, sometimes the stigma that they feel in attending a physical visit. So what we did was we really pivoted in a large way. And at one point, up to 30% of our patients were on some form of teleconsultation or other, whether it was a phone consult or a video consult, with some safety measures in place, ensuring that they could attend clinic if any sort of unexpected complications arose. Now, the global view on COVID-19 and HIV has remained largely unchanged in that we encourage our patients to take the same precautions to reduce the risk of infection as much as possible, to ensure that they have access to and a supply of ready medications, as well as taking care of the general well-being and mental health. And all of these are sort of interventions that we've implemented at our clinic as well. So in that way, the impact that COVID-19 has had on our clinical program has really led to a strengthening and a fine-tuning of the para-HIV services, right? The holistic care that we provide that have been brought up to the forefront as being important during this time of COVID-19. There are some things that we have said not to do as well, switching ARTs unnecessarily unless, absolutely clinically indicated, as well as, not making any switches to boosted PI regimens unless clinically indicated. And this was based on the early signal that, before the clinical trials showing that Kaletra, lopinavir, ritonavir didn't actually have any effect on COVID-19. So I think looking to the future, one thing that clinical programs will really need to look at is during this extraordinary year when some of our patients may not have attended clinic as frequently, will this have an effect on viral suppression, or more likely an effect on the loss of control of other chronic diseases that we are also managing for our patients in clinic, things like diabetes, things like hypertension, things like mental health. And this is something I think all clinical programs, whether in Singapore or internationally, will need to have a larger focus on to ensure that their patients remain well in the long term beyond COVID-19. I'll be happy to take questions during the panel discussion. Thank you very much.
Thank you, Chen Seong. That was wonderful. Maybe just one comment. Some of the information regarding the public health aspects of it, not the clinical aspects, which will be covered in the second panel discussion, I think by Matthias. So stay tuned for that one if you wanted to know a bit more information. Our next speaker today is Professor Martin Chio. Martin is a colleague of mine at the National Skin Center where he's senior consultant, and he's also head of the Department of STI Control. His clinical interests are STIs, HIV, genital dermatology, qualitative research, and skin cancers. He's an avid clinician educator. He was awarded the YLLSOM Dean's Award for Teaching Excellence on 2 occasions. He also volunteers actively at both Dover Park Hospice and the Villa Francis Home for the Aged. Martin, over to you.
Hi, good afternoon. Thank you, Roy and organizing committee for allowing me to share just a short presentation on how the STI services have impacted, the COVID-19 has impacted the STI services in Singapore itself. So you've got all blanked out numbers because these are just provisional, just to show that these are the STI notifications for Singapore itself, and the number of cases for STIs in Singapore where chlamydia, gonorrhea, and syphilis are the most common STIs. So let me just go through how the COVID has affected the services of DSC. DSC not only has the DSC clinic itself that operates in the daytime, the anonymous test site uses our premises. We also do look after brother-based sex workers. We also operate a drop-in center for street-based sex workers. And of course, we do a seroprevalence project. So like what both Eamonn and Chen have mentioned, the main challenge to the situation is basically access to care. When people are unable to go out, unable to do this, and we haven't actually considered the use of tele-services, because most of what we see are acute instances rather than not that many chronic ones. But the chronic ones, we do give them repeat medications where necessary. So thankfully, at the onset of the pandemic itself and up to the circuit breaker, the infectious diseases were considered essential services. So the DSC clinic never actually closed. We continued, but with decreased numbers. Okay, I'll show you the graph later. We've also managed to have open a counter outside for screening for patients. Both we do temperature and also declaration forms. Okay. And you can see that with the declaration forms that come with our patients, it did add a bit of time to the consultation and the entire trip. And you also notice that people may declare on no on one thing, but on further clarification do actually have to re-declare, and some people it does add extra time and sometimes confusion to people entering the clinic itself. We've also had to practice safe distancing within the clinic itself, and we've had the safe distance ambassadors coming to visit the clinic and say that, actually you need to leave more space between the patients. But I mean, so far we've been lucky and we've continued our services thus. And you can see that we've also added in protection for both staff and patients by having these screens between patients and staff. So what has happened, at least for the BSC itself? I think DORSCON Orange, when it first started in February, okay, we actually had reduction in manpower of clinics. We actually closed our evening clinic and our specific women's clinic, and we operated for BAU, business as usual, from 70% down to 50 to less than 50, depending on the situation. We also had to practice prioritization of cases, where we had to look after symptomatic patients, more over and above people who are screening, and of course some vaccinations were put on hold. There was also some issues with vaccination, with vaccine acquisition because of supply chain issues. So that was solved, thankfully, quite fast and easily. The other thing is that our prevention services continued. I mean, prevention sort of was between screening and symptomatic, and our PrEP services still continue. But unfortunately, sometimes some of the patients weren't able to access the PrEP because of supply chain issues also. Certain tests were also cancelled, unfortunately. For example, the lab that was doing the HPV PCR was unable to because of the number of COVID PCRs they had to do. And our RPR kit had to be changed because of supply chain issues also. So during the DORSCON Orange period, the main thing was actually testing, okay, access to care for numbers itself, and of course some medications had some supply chain issues. When it came to the circuit breaker itself, staff that weren't patient-facing could work from home, and sometimes that for coordination of care could have been a challenge. I think I put this point here for MSS, which is the brothel-based sex workers. For them, all the brothels were closed, okay, so they weren't able to work. And they were also, some of them had to go home, okay, and the care for the brothel-based sex workers was not as ideal. We've had one round of screening for them, and the number of cases picked up was very low. But you can see that if people were unable to have sex at the brothels, there were quite a few of cases who came in with acute STIs, who actually acquired it from meeting up with people during the various lockdown periods, and that was also discouraged. Beyond that, we also moved towards counseling for some of our patients, and that has worked to prevent patients staying too long in one area itself. As you can see, Chen also shared the number of cases that they've actually seen. So you can see that our number of cases really dipped between March, April, and May, and then has picked up from June up to a fairly normal stage for the time being. And you can see that with much fewer people being able to go out, there were much fewer appointments also. But you can see that despite that numbers going down, the number of STI notifications dipped a bit during the May to June period, where we had our circuit breaker period, and then thereafter that has sort of come back to unfortunately normal, with some of the probably what we have playfully called revenge sex occurring, and unfortunately the numbers are back to sort of pre-COVID numbers. Okay. So we took to isolating quite a few of our patients and put them into the waiting isolation rooms, and with that a lot of terminal cleaning, and this is our very friendly health worker who has to spend intense hours cleaning and terminal cleaning all these rooms, and of course fatigue will set in. So how about the ATS? I think I'll just one slide here, and then Sumita will actually share more on how there was a temporary closure of ATS, and then they've reopened with decreased numbers. Safe entry, okay, considering the ATS as a normal site, they use actually safe entry, and that was all right for the safe entry. For our street-based sex workers, we closed our center in early February just as DORSCON Orange started. Okay, but even though the center was closed, we were still handing out items to the sex workers when they came through the grills itself. When the circuit breaker started in April, we closed the entire center itself, okay, and then it's been reopened since September itself, and activities have resumed. We also happen to run this MSM Zero Prevalence project along with AFA. Because of the situation, the numbers have actually reduced. Some venues have actually closed. Okay, so we're doing a scouting review at the end of December to see. So what have we learned from all this? As you can see, that Chen also mentioned that they didn't screen as much for STIs. We did some screening. Our numbers have actually come back up to normal and regular, sorry. And we need basically a lot of buffer, not only in terms of medications, in terms of staff manpower, in terms of testing kits, and that will also impact. Teamwork, of course, cross-training, because when people are working from home, other people have to take over. We also had some of my nursing colleagues were also sent to the community care center, so the nursing staff decreased, and we had to adapt and innovate.
1 minute left, Martin.
Okay. We had to continue teaching medical students, and of course they couldn't sit in with us. So we actually devised STI scenarios for medical students with simulated patients. We created a safe sex video for those who are continuing to have sex. And of course, had many ideas to try to maintain the morale, spirit, and prevent burnout for patients. All of us who continued working throughout the entire pandemic and still continue. And of course, having learned all this, we are expanding our services with a new STI clinic at NSC. And with that, we can also consider and planning how we relook the design and the workflow so that if another one happens, we will be prepared. Okay, so this is the website for our clinic itself. And of course, a big thank you, of course, to my nurses who have spent a lot of time caring. And this is Rishi and Hairi. So I'll be happy to take questions from the end.
Thank you, Martin. Thank you very much. We'll push on. Our next speaker is Sumita Banerjee. Sumita is the Executive Director of Action for AIDS. She has almost 20 years experience in public health, having worked in India, Canada, and the UK before coming to Singapore, where she has been leading the team at AFA for 5 years. Prior to joining AFA, Sumita worked as the Global Advisor for Planned International UK Sexual and Reproductive Health Programs, based out of the office in London. Before that, she worked in Toronto with ICASO, the International Council for AIDS Service Organizations, leading their HIV programs globally. Over to you, Sumita.
Yeah. Thank you. Thanks, Roy. I'll be talking about the impact that COVID has had on the community HIV program. So AFA, for those of you who do not know, is the leading community-based provider of HIV services in Singapore. And we really target the two main populations that are affected by HIV in Singapore. And we also run a number of programs for persons living with HIV. Okay, so I think Eamonn, when he spoke, he briefly talked about the timeline before me. Seong has also mentioned it. So just keeping the 4 blocks in yellow in mind when our programs actually started to go down. So March, when WHO declared COVID as a pandemic, and the impact that it started having on our programs. Again, it was in March that we started seeing community cases go up in Singapore. In April, when the circuit breaker, or essentially the lockdown, was put into place. And then from July, as Martin mentioned, there was easing of some of the restrictions and our programs could again go back on. But I'll talk about this a bit later. Some of our programs actually did continue during the circuit breaker, but we did see a substantial decline in the number of clients that we usually see than what we usually see. So the impact of COVID-19 in terms of what it meant, there were lockdowns, so clubs, saunas were shut down. So these are actually basically where we carry out most of our outreach work. So our awareness raising outreach work is carried out through the clubs and the saunas. And because these were essentially shut down, we could not go there. Most of this outreach that we did was put on hold. There were also restrictions in terms of gatherings. There couldn't be gatherings of more than 5 people, which meant that our MTS service, our mobile testing service, also had to look into those kind of restrictions and then accommodate clients based on these numbers. Chen Seong just mentioned that there was a diversion of healthcare providers to COVID response. Clients were not encouraged to go to hospitals, and even so, there were issues around linkage to care possibly, but also around with regards to health services. There was also a fear that many clients had to come and get an HIV test in a clinical setting. So we run the anonymous testing site, and even before we put in restrictions, when the numbers had started to increase, we did see a slight drop in the number of clients that we started seeing from March onwards. So again, looking at HIV, when you have a stay-at-home orders coming from when people are encouraged to stay at home, when safe distancing or 6 feet distancing is kind of being mentioned everywhere, it's also difficult to come to test because the counselor would actually the person would have to share their sexual risk-taking behavior, and this also has implications in terms of maintaining that safe distancing, staying at home, meeting only family members, and all those COVID-related, lockdown-related restrictions that have been put into place. And a person might feel reluctant to talk about risk-taking behavior or sexual risks that they might have engaged in. So this also had an impact and has an impact in accessing services. I'll just briefly go over this. Eamonn talked about it in detail. So if we look at this, if we look at the testing data from UNAIDS, we really see that the downswing really started in March and it continued up to June. UNAIDS actually released data which said that HIV testing is the service that was most impacted by COVID. Similarly, there's data which has come out of the Global Fund. For some reason, it doesn't show up the whole screen. But if you look at this, at the pie chart here, there has been a disruption across all 3 major disease areas. And the disruption in HIV services has been up to 80% in most countries where the Global Fund delivers programs. So what impact did it have on our HIV prevention, on our community programs in Singapore? Now, AFA essentially runs prevention, testing, and support programs for persons living with HIV. So we really target 2 of the main populations that are affected by HIV based on the epidemiology in the country. These are high-risk heterosexual males who have multiple partners and men who have sex with men. Now, before I go in, I just want to highlight that we have a small team and we only reach up to about 25% of those populations who are at risk for among the high-risk heterosexual males. And for MSM, we reach 30% out of a total population of approximately 210,000 men. So what did it mean for us at this point in time? With the lockdown, with clubs being closed, many of our programs actually had to be shut down. So the clubs were closed, so there was no outreach happening. So what we essentially do is we organize big events in many of the clubs, we distribute collaterals, try to raise awareness among those who visit these clubs around, build their awareness on HIV, urge them to go and get tested. So none of this was happening. The transit point, it basically targets those who go out of Singapore to buy sex, mainly by using the ferry or the bus service. So if they were not going outside of Singapore, there is a possibility that they were buying sex within Singapore, but then we were not being able to reach them either. Coffee shop outreach that targets blue collar workers. Now Singapore, and I think it will, when Matthias later gives the epidemiological update on Singapore, a lot of the late presenters in Singapore are actually from this group. And none of our programs were able to reach them during the circuit breaker. But of course, the one that's in yellow, the blue collar outreach work has now since started, given the restrictions that are happening. The same with MSM, the venue-based outreach programs, where again we organized events, had the MTS van, had huge queues lining up. None of this could take place. Pink Carpet Youth program, which is actually for young MSM. And as Eamonn had mentioned, infection rates are rising among MSM. We are seeing that in Singapore as well. We have not rising infection rates, but among those who are newly infected, the populations, the age of the population, it's a younger population group. And we actually had to suspend the drop-in sessions for them as well during the circuit breaker. Testing at ATS, it was suspended temporarily, but then it was designated as an essential service. But again, we did restart it, but with several restrictions in terms of the number of persons who could be at the clinic at one point in time. So if you look at this graph here, in 2019, keep in mind, like I said, we reach only 30% of MSM who are at risk of infection. So in 2019, we reached about 56,000 MSM, and the number in 2020 was almost half of that. If you look at the condom distribution, again, close to 60,000 in 2019, less than half of that in 2020. So essentially the number of MSM that we were able to reach in 2020 is about, through a ballpark figure, it comes to about 10% of those who are at risk of infection. Now if you look at this pie chart, this comes from our ATS data. More than 50% reported inconsistent condom use. But then if you look at the information that we could provide, we were reaching less than 10% because of COVID this year. Now, like I said, we only reach a certain proportion of those who are at high risk. And many of them actually are not even there at the venues that we do outreach in. So how do we try to reach out to these groups? So well, we do educational awareness programs. We use various other platforms. We do stigma reduction talks. We talk about discrimination. We try to highlight the importance of getting tested early at workplaces, higher education institutions, and of course, with working from home, all of this stopped as well. We did reach out to many of the companies and workers who we did target earlier, asking them if we could do it by Zoom, but then many of them came back saying that all their meetings are by Zoom, and there is some sort of a Zoom fatigue that is setting up among their staff as well. So alongside that, our women's program, the youth sexual program, wherever there were workshops, capacity building programs, all of that actually came to a standstill during the circuit breaker period. Our support group sessions that we run for newly diagnosed persons, even that was put on hold during the circuit breaker period, and we were eventually able to start it towards the end of July, early August, with some of the restrictions being eased. So this is something which I just took when I was doing my presentation. I found this interesting data, and I thought that I should put it here. So there was a study done by a research group in Singapore, and they found that 53% of the population who they interviewed felt that that COVID had affected their mental health. And I was just wondering what the impact must have been on, or might be on, somebody who has been newly diagnosed but has no peer support mechanism, no channel to fall back on. Of course, our staff did continue to provide counseling to newly diagnosed persons through the phone. Whoever tried to reach out to us by email, or by contacting us, we actually did provide that service to them. But this is really about those peer support groups that AFA convenes and coordinates. So if we look at testing, you will see that there was a sharp dip in April, May, and June. And then again, slowly after the easing of restrictions, it has started going back up again. The same is for the mobile testing data, because that service had to be shut down, that service went down even further. So if you here look at the uptake of HIV testing among MSM, you look at the numbers in May, that has really plummeted down. So that's just after this circuit breaker, even though we were running at that time, the numbers have really dropped. And then if you here see the number of clients that we've seen in 2020 compared to the other years, there's a sharp drop here as well. In terms of treatment disruption, this is specifically probably related to those who do not access treatment in the institutions here in Singapore. So we had about 110 PLHIV who reached out to us during this period, asking us to connect them with alternate sources of treatment, because they either traveled to Bangkok or for whatever reason, they were not able to access treatment. And this is probably, like I said, not those who are, it probably comprises mainly of foreigners who were stuck in Singapore during this period, or those who are not in the system accessing treatment from the institutions here. So what is it that we need to do? So we really looked at, from our perspective, we tried to digitalize some of our programs. So for the MSM community, the capacity building workshops that we deliver, we try to take these online. So we started offering webinar sessions. We started doing online drop-in sessions for young persons, for PCY, which is the Pink Carpet Youth or Young MSM. However, do bear in mind that a lot of them in Singapore are still coming to terms with their sexuality. They are young boys who still stay with their parents at home, and probably the home does not offer the best space to be able to access these webinars. And we did actually see that the attendance in our online drop-in sessions was actually far lower than what it was when we were actually hosting it.
Sumita, you've got 1 minute more.
We also launched a video campaign trying to reach out to MSM and through drag queens. We try to use the social media to reach out and to spread information on our programs as far as possible, raise awareness, provide prevention programs. So one of the things is innovation would be key in the coming months. I think, as every speaker before me has mentioned, we are looking at bringing our counseling services, pre and post testing services online, and also having a hotline service possibly for those who may not be comfortable or who may have additional questions to ask. Also, we are looking at the possibility of offering test results online, promotion of self-testing. I think that's critically important, and community sources there has to be a community source providing those self-test kits for individuals who might not feel comfortable to come and get tested at this point in time. There also has to be looking at more innovative systems of allowing PrEP access for those who need it during this time, possibly through linking them to some services, offering it more through the community. And then again, like I said, given the number of those who faced treatment disruption, it's also critical to look at providing those access points to individuals who might not be getting treatment. So over the short term, though the lockdown and safe distancing might have led to a reduction in risk-taking behavior, over the long term, we know that any disruption in educational outreach will have longer-term consequences. There has been a UNAIDS study which was done, which found that that any disruption in provision of prevention programming and availability of condoms over 6 months can actually can contribute to a 30% increase in new infections over a period of time. And that's something I think we really need to keep in mind. Now is the time we have to find every opportunity to look at ramping up our prevention and testing efforts, providing, ensuring those psychosocial support mechanisms are available for PLHIVs, and then also providing some pathways for accessing treatment for those who might not be in the system. So I just want to end by this short quote. It's actually a study which was done by the WHO, which did a bit of modeling, and they found that wherever there's a that it mainly applies to sub-Saharan Africa, but it's equally relevant to every part of the world. Seeing any disruption, short-term disruption in services can actually have a far longer-term impact in terms of HIV gains that have been made over the last 10 years. So yeah, so that's something to be kept in mind. So that's all. That's my presentation. So if you have questions, I look forward to answering them. Thank you.
Thank you, Sumita, for a very comprehensive presentation. Lots of things to think about again. We move on to our fourth speaker, Vanessa Ho, who is the Executive Director of Project X, which is an organization providing social, legal, and emotional support for sex workers here. This is a position she has held since 2011, and one that has provided her many opportunities to meet and connect with sex workers both here and abroad. She has written and spoken about sex work, human trafficking, rape culture, LGBTQ rights in Singapore. She holds the view that if people can speak about sex, gender, sexuality in open and non-judgmental ways, society will be a much safer place for everyone. Vanessa, over to you.
Thank you, Roy. Thank you for the introduction. Thank you, everyone, for giving such inspiring presentations for me. I think feeling a little bit of an imposter syndrome right now, but I'll do my best and probably give you a ground-up understanding from the sex workers' perspective. Okay. Getting control of my slides. So I'll very quickly talk about 3 things today. So challenges during COVID-19, now initiatives and programs, as well as next steps. So as you might know, the sex workers during circuit breaker, the entire sex industry closed overnight. First was the entertainment industry, right? Bars and clubs closed first. And then later on, we had the circuit breaker, which meant that street-based sex workers, online-based sex workers all also had to stop work. First, from the perspective of sex workers, almost all of them had 0 income overnight. So as you know, sex work is a job where you earn when you work. And if you don't work, you don't earn anything at all. And also there was very limited access to government schemes for sex workers because the running joke is that sex workers don't issue invoices and receipts to their clients. And so they could not prove that they had employment and they could not prove that they lost their income due to the circuit breaker. Some people managed to access some kinds of funding, but most, especially the COVID-19 support grant was excluded many sex workers. I think earlier on, we definitely spoke a little bit about how the COVID-19 pandemic really exacerbated many of the inequalities, existing inequalities in society, and disproportionately affects people at the margins. And I think sex workers were definitely one group of people who were disproportionately affected. So very quickly, just an overview of the different types of sex workers in Singapore. So the regulated ones, the entertainment-based ones, street-based sex workers. For now, some street-based sex workers have managed to go back to work, but most actually are not able to work. Massage parlors opened back in phase 2, so they have been operational. Online-based sex workers, it really varies, depends on whether they have access to short-term rooms as well as hotel rooms in which they can carry out their service. Digital sex workers is a new space, and that's something that we're also trying to understand a bit more and also reach out to as many people in this space. But we're talking about your OnlyFans content creators, your webcam sex workers who may or may not have in-person sexual service may not provide in-person sexual services. So there is an increased consumer base from what we observe for digital sex workers, but also increased competition. Many people ask us, why don't sex workers, explore going online for their providing services? But it actually takes a lot of technical know-how, understanding how technology works, understanding how to protect your identity in the digital space, how to make sure that nobody is able to stalk you and harass you and all that kind of stuff. So it's actually a very niche kind of skills, and not everybody is able to do that. So with the circuit breaker, for us, we were considered a non-essential service. So our drop-in center as well as our outreach services all had to stop. And so we really had to think of ideas of how to pivot. So for example, our condom distribution and our safer sex education programs all took a pause because we spent a lot of times on the streets in person talking to people. So as our STI as well as our HIV testing programs, all of them had to be halted during the circuit breaker. And it took a little bit of time. I think only in phase 2 and sort of only very recently did we manage to restart our STI and HIV programs. We did focus a lot during the circuit breaker on online outreach, running advertisements, also ramping up our social media efforts. So I think Mr. Murphy talked a little bit about using the digital space for sexual health education, and that was what we tried to do. And we managed to target a very, very different kind of audience. So people who are much younger, much more tech savvy, who really spend their time on spaces like Instagram. We were thinking of starting a TikTok, but that was kind of over my head, and we're kind of just waiting for people to teach us how to use TikTok and all that kind of stuff. So one of our biggest pivots was that we actually, so I'll give you a quote here just from one of our beneficiaries, Mita. She said that the pandemic has been tough for me and my fellow sex workers. Uncertainty and fear for our safety took over us from the very beginning. Her story is on our Instagram, so if you can go check that out and give us a follow, that would be really great. So we really pivoted during the circuit breaker and sort of shortly after the circuit breaker as well, and we moved into financial aid for sex workers. So we did We Are Still Here For You initiative, which was a mass distribution of grocery vouchers initiative, and we reached about 160 sex workers just by doing that. We had a food delivery program because there were sex workers who really had no savings, and what we found out for many sex workers is that because they have a lot of dependents, they never really get the space to save up enough money. So whether it was providing for their children, for their elderly parents, or just for their own sustenance, for example, hormone replacement therapy, all of those things cost money. And so it was very hard for sex workers to save up. And we started to see a lot of those people falling through the cracks during this time. And so food delivery became a necessary program for us to run. The last one we did was an emergency safety net program where we actually provided sex workers of up to $800 in financial aid if they were struggling. Here's just a rough breakdown of the different types of requests that we got. So people could not afford food, could not afford rent. There were many people who were on the verge of being evicted, and we had to step in. We had to negotiate with landlords. We'd be like, hello, you know, it's the pandemic. Can you, you know, just not kick people out during this time? Where do you think they're gonna go? We had to refer a few people, homeless people as well, to the government's homeless hotline. We had to call MSF and refer people to those spaces also. Bills were piling up for many people. And for medical, thankfully, I think Singapore has good social safety net in this space, but there were still some people who could not afford their medical bills, especially the migrant sex workers and entertainment workers who were absolutely not allowed to apply for local government support schemes, COVID relief schemes. So this was one of our biggest pivot, and we dispersed over $75,000 across our 3 initiatives and impacting the lives of about 200 sex workers and their families. Yes, so moving forward, we have managed to reopen our outreach as well as drop-in centers gradually since 19th of June, which was phase 2. So the changes was that we had safe entry as with everybody else, and now we have to think about moving into Trace Together also, I think the other initiative. But one of the things is that we have to seek new ways of safely providing STI tests. We used to administer the STI test throat swabs for people, and now we have to move into learning how to teach people to self-swab. And we sort of taking a page out of many of the new initiatives that we are starting to see of STI home testing kits, right? So people who, I think there are a number of private companies right now selling home test kits. And so we learn from them, how do they teach people to use these test kits effectively such that they can take enough samples for an effective test. So those were one of the things we had to research about. And now we have videos at our office that show people how to administer the test on themselves, for themselves. So yeah, changes in our outreach. I think using ESNPs, or financial aid programs, were really important to publicize our organization. It was really about meeting sex workers where they're at, right? They're thinking, you know, of survival. They're thinking, oh my God, my business has dipped almost to zero. Even now, people are saying their income is about 50% of what their income was previously. So talking about sexual health is really not at the top of people's minds. And meeting people at financial aid was really a way for us to be like, hey, you know, I know you are struggling. Here's some financial aid. And then you can also access the other services that we provide, which includes STI and HIV testing. And that's where we can open up the conversation about sexual health and how to take charge of their health during these times. We also had to advocate ways to stay safe during COVID-19. I think there were quite a number of infographics going around, and I think in New York released how to have sex safely, what are the kinds of sex positions that you should take in order to prevent STIs and HIV, prevent COVID-19. So we tried to use that. I mean, it was a bit, we were not fully convinced, but it was a fun topic to talk about. And it was also a conversation starter as to how to protect themselves during this time. Because sex workers are very worried, right? They tell us like, look, I have elderly parents at home, I have children at home, and I don't want to be the cause that my elderly parents fall sick because of their work that they have to do. Yeah, so instead of condoms, we also started distributing hand sanitizers and masks, dissemination of information, debunking fake news. Thank you. It was also a very big part of our work, because I think it was very clear that it was also a pandemic of disinformation and misinformation, and we really wanted to be at the forefront of countering that. Assisting sex workers to adhere to COVID-19 safety measurements. People were like, how do I get the QR code? How do I paste that on my wall? How do I do the travel declaration? We had to print attendance forms for some of the sex workers so they can put it at their shop so that their customers could also sign those travel declarations. So those were some of the things that we had had to do. Yeah, so what's the future of sex work in Singapore? Massage parlors are still very much active. I think that was really one of the spaces where we could do a lot of our outreach. Entertainment establishments pivoting to F&B. We are starting to see migrant sex workers coming in. We don't know how, because I want to know how to get out of Singapore, but they're managing to come into Singapore. So I really want to know how. Really observing in this space. But we are very worried that the sex work industry is moving much deeper underground, right, to HDB brothels and online sex work. And they're moving so fast and so deep that we are very worried that we're no longer able to outreach to them. Digital strategies might work, but it really depends on our ability to translate our materials to the different languages, tap on the different platforms, because different nationalities use different platforms, right? Filipinos would use Facebook, Vietnamese would use Facebook, but Chinese people would use Weibo and WeChat. So really having to learn all these digital strategies is really going to be our next challenge into the next phase. And yeah, we have seen some sex workers moving out of the sex industry, not a lot, but that is something that we're also observing. Okay, I think that's the end of my presentation. Thank you, and happy to take any questions.
Thank you, Vanessa. I think that was very riveting and extremely inspiring. Excellent work you're doing. Thank you very much. We have we have some time for comments and questions, but I'd like, first of all, maybe to invite Eamonn to make a few remarks if you have. Thank you.
Thanks very much, Roy. Firstly, let me say this has been really informative for me, and I've learned a lot because in my work, I often see the broad data, the broad information points. And so to be able to listen to such knowledgeable speakers about what's going on in Singapore across the board is really informing me, because often we may make the mistake and assume things are differently in an advanced economy type setting like Singapore compared to other countries, and our focus is much more on other countries. But a couple of points, Vanessa, that was really deep, rich information around the challenges for sex workers, and that we've seen in so many settings. They are the informal workers and the least able to access social protection, often without papers, without evidence of employment, and so this has had such a significant impact. There's been some good examples in different countries of responses, but many have not been able to have the benefits. We have seen some preliminary evidence of increased risks of suicide for key populations because of the mental and emotional strain because of finances primarily as part of this. And similarly, Sumita, the data you shared about types of services and the shift in services, the drop off in access to services, that confirms what we're seeing elsewhere. We are expecting to see in some places new infections rising because of the lack of access to some of the basic commodities. Some are questioning, of course, what decline in casual sex during lockdowns, during different forms of responses, personal responses often to the epidemic. But the other last point, Roy, if I may, I think we can't go backwards on these online. Vanessa triangulate the whole range of different types for different parts of the community or clients, but we can't go backwards after and whilst we continue with COVID, but post-COVID, we must move into this new age of different forms of service outreach. And so that's going to challenge some of our comfortable service providers and more familiar access points. But this is the new reality. So thanks very much, Roy. This has been really
very good remarks. Perhaps taking up from the point regarding we shouldn't be thinking of going to pre-COVID. This is, if anything, we need to learn from the new ideas and the new ways of working that we have to scramble and then take it from there and not think that we want to go back to old practices. So I guess my question maybe to Chen, Seong and to Martin is will this experience of COVID be greater impetus and greater fuel for our advocating for better, more rapid rollout of self-testing, number one, and number two, how can we change our PrEP delivery and dispensing program so that we don't need to have patients come in, to see doctors. That's the first thing, and for Martin, I guess maybe if I can ask the question, what have we learned and that we can change the way clinics are run going forward? So maybe Seong first.
Okay, thanks so much, Roy. So I think with regards to the first question about HIV self-testing, definitely I think the COVID-19, we are never going to go back to the way we were before. And so self-testing will truly have a role in that. So in terms of expediting its rollout, I think I think there are a number of things at play, but what I can say is that a pilot for or a rollout or a demonstration project for HIV self-testing is definitely on the book. So we hope to be able to roll that out really soon. As I sort of said, and many people have echoed, many of us who are in the HIV sphere, whether in our public health or clinical care capacities, are also involved in COVID-19. So I think some things have been delayed just as outcome of bandwidth. Now, with regards to PrEP and sort of pivoting to online, I will say that now in my own PrEP clinic, I see more than half of my patients offering them teleconsultation on alternate visits. So I still see them physically once every 6 months or so, but alternate visits on 3 months, they get their test done and I sort of have a chat with them on video consult, give them they pick up their prescriptions, whether they're buying them, on their own or from our pharmacy. So we have pivoted not just in terms of HIV care, but prevention in the online sphere as well. And this has helped, I think. Hopefully, we'll be moving into a place where, like in London, where they do self-testing for STIs and so on. So all of that is on the books. We are planning for them, but implementation and intervention may take a while. Thank you.
Yeah, thanks, Roy. I mean, I agree this self-testing will be a lot much easier. I mean, there are some groups that have started getting your kids online, sending your kids that, as Chen said, these ideas are fantastic, but I think the implementation may take a while. It would be great if patients can just we have a small room outside the clinic. You pop in, do all your testing, pop in, that it goes straight to the lab. No worry about transport, no worry about storage and stuff like that. And then you get your results a few days later. And then if you need to come in, you come in. If you don't, then that's the end of the story. And all this can be done through various means, through text, to WhatsApp, through various we log into a website and stuff like that. That'd be great. As for the PrEP delivery, I mean, I think some of our limitations really having patients needing to come in to do various tests, and they do need sometimes a rapid HIV test before getting their PrEP as part of the program itself. And if they could do their own self-testing and could prove I think that'd be a fantastic idea. So I think PrEP, this COVID crisis has actually made catapulted some of our advances a few years down the road. I think so. I think it's a good thing. We're not happy to have it, but I mean, it's a good thing to help move some of these things online and secure online platforms on top of that.
Thank you, Martin. I have a question from Sunita from Jason Ong. How did you measure treatment disruption?
Actually, we measure treatment disruption based on the number of PLHIV who approached AFA to link them up with services, saying that they were unable to access their medications, and they wanted us to link them up with alternate sources where they would be able to access medication. That's one. The second is we also did a research study with PLHIV. The study is not out yet. We supported another partner to do the study, and there were a few questions around reporting by PLHIV on disruptions or interruptions that might have happened in terms of access to medications, and there were actually about 25% who reported some sort of treatment disruption that they had faced in terms of accessing medication. But a lot of them are not linked to institutions in Singapore, and many of them are actually foreigners.
Thank you.
Maybe I can jump in just to say that we have received many of these referrals, and at the clinical centers, I think we are seeing patients who are either foreigners not seeking care in institutions, but because we don't want them to have treatment interruptions, sort of jumping in and providing alternative sources of medications, at least in the interim, just as a service to make sure that they don't fall short. So we see them, give them the medications, and then hopefully their next visit, they can go back to where they're already seeking care. So I think in this way, we try to keep the continuum as unbroken as possible.
Thank you, Chen. Going to Vanessa, you mentioned earlier on regarding certain charts regarding safe sex positions. I think at the height of the COVID COVID epidemic in Singapore, in DSC and also AFA, we also came out with charts, and I thought it was quite interesting. Might have re-energized our discussion regarding various types of safe sex. I don't know actually if people would actually follow such positioning during sex in the era of COVID, having sex in the era of COVID. It would be interesting to see if there's really good data to show that COVID is spread in certain sexual environments. I don't think I've seen any reports yet. Everyone was concerned that when people resume having sex, they would also be transmitting COVID virus, but that remains to be seen. Do we have any other questions in the group chat or in the Q&A, Chen Seong, that need to be responded?
Yes, maybe one last question is a question, I think sort of related questions to Sumita. Able to share more about such services as online risk assessment for prevention, or even whether chat groups like on WhatsApp and so on being considered as form of online access for young MSM. So I think just maybe a little bit of elaboration on the movement to online services provided by AFA.
Yeah, actually, this is a service which has not started yet. It was as part of some of the recommendations that we put. We are looking at digitalizing some of the offerings and looking at bringing online risk assessment, doing an online risk assessment, and then linking those up with PrEP providers, to be able to access PrEP. So these are all things which are like, the whole situation has been evolving, and we've also started looking at different formats and different ways to take it further, be it through online, be it through WhatsApp chat groups, be it through webinar formats. But with young MSM, we found that the webinars are really not that popular because they are at home. But we have been doing these counseling sessions through WhatsApp. But then the feedback that we get, and of course, like Eamonn said and the others have said, that COVID has actually thrown upon us a new way of looking at things, and this is probably the way to go, and we will adjust eventually. But currently the feedback that we've got is that it's not the same as meeting face-to-face and being able to share face-to-face, because even within a WhatsApp group, there are always issues of safety, security. How much do you share? Is it a closed group? So those kind of questions have been raised.
Thank you. I guess I have one last question for everybody in terms of funding. I think from Eamonn, from the point of view of the donor funding and then the HIV program, the STI program, and also community, and certainly the AFA as well as the Project X. What do you think would be your short to medium term impact of funding for your programs? Maybe we start with Eamonn from the international perspective. Would donors is there any feedback from donors yet?
Thanks, Roy. There is expected to be, not yet. There wasn't an immediate shock to the system like there was, say, with the human movement as a result of the Syrian crisis and others, which had an immediate flow on. But the expectation is in the medium term, there will be a reduction in development assistance, which will include HIV. Economies are suffering, so we will see it. That's the expectation.
Chen Seong, any comment?
No, I think that's all the questions that we have.
Oh, okay.
Are you asking me about funding?
Yeah, I'm asking.
Apologies. I think that only in as much as most funders, especially governments, I think, are going to be prioritizing the immediate issue of COVID-19, obviously, and especially in terms of getting therapeutics and vaccines, I think, increasingly. And especially where purse strings are already tight, there may be some, some compromises or some corners that may have to be cut. And I think it's always going to be tempting to say that, things that have been running all these while, including HIV and STI programs, may fall by the wayside. So I think it's especially important for us in the field to continue to talk about HIV in this field, in these spheres, and say that actually not only are the programs important, but that there are many lessons and sort of byproducts of our fight against HIV that have actually been used in the COVID-19 response, and hence we can't afford to roll back all of the gains that we have made over the last couple of years. Yeah.
Thank you. Martin, anything to add? Anything regarding?
Well, I think maybe the funding can be for our programs will be really is probably more manpower and more space, because because people multi-hat, we do run our own derm services also. Our nurses will have to go, and the medications lab. I think it's a whole programmatic sort of thing rather than just one particular thing. And if we can, as you can see, once our numbers were down, notifications went down. But once our numbers resumed, notifications have resumed back to background level. So that definitely is a need for continued, maybe more funding in terms of having a buffer for manpower. Because if people have to go away and do other things other than their primary jobs to look after a pandemic, then these sort of services will definitely be compromised. That's why I said buffer as one of my first lesson points.
Well, of course, Roy, I think when the economy suffers, the funding also suffers, because for a community organization like AFA, there are grants, but there are also individual donors who provide funding, right? So individual donors, when the economy is tight, they will also tighten their own funding belts. So of course, then the other piece are the corporate partners that we depend on, and we are hoping that they will continue to fund our programs, but we also have to be a bit realistic, because when the bottom line suffers again, the first cut is made to community programs actually. So that's the sad reality. But like I think Seong said, it's just that despite all of this, we should not roll back on all the gains that we've made in the past 10 years. So we just have to continue to push the envelope and try to make the best. Yeah.
Thank you. Vanessa, you have the last word.
So I think we were only able to provide the financial aid programs to sex workers because of the generosity of donors during the circuit breaker. And we were so overwhelmed with the number of people who wanted to support our programs, and to also see us support sex workers in a very real and concrete way during this program. So we're very, very humble. I think during the period we were like, oh my God, there were actually so many people who will want to support sex workers, who will want to see sex workers not face discrimination, and want to see them prosper and be able to survive this pandemic. So we're very thankful for people, and we're just hoping that people don't run out of steam, as we've heard the word fatigue many times in terms of Zoom fatigue, but also donor fatigue is also an issue. Yeah, I do want to also echo what Martin was saying about burnout a little bit, right, among staff and volunteers. I think we really rely a lot on people coming through during this period of time to lend their emotional support, to drive the food around Singapore, to be taking phone calls, to listen to sex workers talk about their difficulties. And burnout is always a problem I think we face in community organizations, and more manpower and more space to take care of our mental health is definitely something that I would love to see. So yeah.
Thanks very much. Okay.
Then we get Eamonn to host us in Bangkok one day. Yes.
Yes.
Okay. So we'll wrap up this the first webinar and first panel discussion. Thank you again for everybody for taking part, for the audience for submitting the questions. We're going to take a short break now before the second webinar, which starts sharp at 3 p.m. Thank you very much, and stay tuned. Don't go away. This is the next one's going to be very interesting as well. Okay, bye-bye.
Thank you all the speakers for sharing your insights and expertise. And thank you for those of you who have raised great questions in the Q&A sections. After the break, we will talk about progress on the community blueprint and HIV in Singapore. So stay tuned.